Okay. Welcome everyone. Good morning for most of you. And we're really excited to kick off this session on occupational licensing in specialized markets. I'm Abby Wozniak. I'm with the Minneapolis Fed and I'm the director of the Opportunity and Inclusive Growth Institute there, and I'm chairing this session. But we're all really grateful that it was organized by Kleiner, who is here today as well. We have a full program with 4 papers, and so we're going to get started right away so that every presenter can have their full 15 minutes and discussants can have their 10 minutes. There will be time for Q&A, and I will try to work those in paper by paper. So if you are in the audience or you are another panel participant, please put questions in the chat. I'll be watching that, and I will call on folks and try to get questions out in person or read them myself if I have to for time. So with that, I'm going to turn it over to Wenchen Wang, who is going to be presenting occupational licensing in the public sector. And that will be followed by a discussion from Darwin Deo, who will pop up after Wenchen finishes. Go ahead, Wenchen.
All right, thanks, Abby. So hello, everyone. I'm very honored to be here to be able to discuss with you guys about licensing in this session. So today I will present the paper of occupational licensing in the public sector, which is co-authored by Professor Kleiner here. So this paper mainly looks at 2 research questions. The first one is, how would licensing affect workers' choice of employment into the public or private sectors? And we find that licensing is positively associated with workers' selection into the public sector. And we also want to examine how licensing in the public sector would affect labor market outcomes, include hourly wages, total weekly hours worked, and employment. And we find that licensing in the public sector positively affect wages and hours worked and negatively affect employment. The effect of wages is around 6%. The effect of weekly hours worked is around 5%. And total employment effect for licensing in the public sector is around negative 28%. So the uniqueness of this analysis is that is the first one to examine the effects of occupational licensing and the public sector. And we also, in this analysis, use several robustness check methods, such as subgroup comparisons, to check the validity and implications of our main results. So just a little bit of background, occupational licensing has increasing and larger coverage compared with the traditional topics of minimum wage and unionization. And the number of licensed workers has increased from 5% in the 1950s to 22% by 2018. So in terms of licensing effects, there generally exist 2 stories. Due to licensing's increased educational and training requirements, it can serve as barriers to entry for practitioners. And also because of these educational trainings and requirements, it can also serve as job market signals for quality, not only for consumers, but also for practitioners. In terms of the labor market for public and private sectors, the major difference exists in that in the public sector is more of politicians and the bureaucrats will take a greater role, while in the private sector is more of a market environment, which is largely determined by supply and demand. Therefore, the objective function is also different. In the public sector, politicians and bureaucrats will focus more on social welfare maximization, while in the private sector, it is more of the decision maker will focus on the marginal product performance pay, where the marginal product of workers are key determinants. Just a little bit more background, licensed worker in the literature also always find a wage premium, and the magnitude of this premium ranges from around 6% to 15%. In licensing generally, it will increase hours worked and reduce labor supply. So the increase of hours worked is majorly due to the increase in wages, and the reduction in labor supply is majorly due to that licensing can cause the substitution effect to dominate income effects. So in terms of working in the public sector, the literature has found ambiguous effect of working in the public sector on wages, but positive compensation effect. And the effects of working in the public sector on employment are rather inconclusive. So in order to answer our first research question about how licensing would affect the probability of sector choice, we adapt a discrete choice model from a paper in 2018 by Lan and Palacios. And the main logic of this discrete choice model is that public sector workers are more risk averse because of the job stability associated with public sector occupations. Also, similarly, because licensing will reduce unemployment and increase wages and compensation. So licensed workers are also more risk averse compared with unlicensed workers. Therefore, licensing can serve as a proxy for the risk aversion when we consider workers' choice into the public and private sectors. And we establish different utility functions in each sector D for workers. So the derivation of this utility function is out of the scope of this paper, but the implication from this model is that risk-averse individuals proxied by licensing are more inclined to select into the public sector. And in order to answer our second research question about how licensing will affect labor market outcomes, we adapt a welfare analysis model from Kleiner and Sodas in 2019. So the implication of this model is that the licensing's barriers to entry can shift the supply curve to the left-hand side from S to S prime, and the job market signal for quality of licensing can shift the demand curve from D to D prime. Therefore, licensing will result in a reduction of labor supply from Q to Q prime, which is a welfare loss, and it will cause an increase in the price from P to P prime, which is presumably a welfare benefit. So we predict this welfare loss and welfare benefits effect of licensing to be similar in the public sector. So our data comes from current population survey, covering the ranges from January 2015 to May 2021. And our licensing attainment indicator is constructed from 3 research questions starting to be asked in CPS in January 2015. And this licensing attainment indicator refers to when the license is required for an individual's job, and the licensing is also issued by the federal, state, and local government. So following the literature, our sample includes employed workers ages 16 to 64, and we exclude self-employed workers, members of the armed force, and people who are unpaid family workers. When this licensing questions in the CPS are only asked in the 1st and the 5th month, therefore, any changes for the licensing attainment indicator in between those survey months would not be captured. Therefore, but they're imputed in the CPS. Therefore, in order to clean those imputation and in order to construct the most accurate licensing indicators, we adopt a method from Kleiner and Shishir in 2020 to clean those licensing attainment indicator. And the final sample contains over 700,000 observations, of which over 300,000 are unique individuals, and they are spread across over 440 occupations. So let's look at some mean descriptive statistics. We can see that in the whole sample, licensed workers account for 15%, while the majority are still unlicensed population, while people who the share of people who work in the public sector is around 14%, and the majority still work in the private sector. And one thing to note here is that when we look at the licensing share in the public sector, the number almost doubled from 15% to 29%. And this is the reason why we want to focus on licensing effect in the public sector later. And similarly, when we're looking at the share of public sector, the number also almost doubled compared with the whole sample, but the share for licensing and working in the public sector in the private and unlicensed group are comparable to that of the whole sample. And we also look at some labor market outcomes mean. Here we can see that for the whole sample, workers on average earn $26.6, and they work annually on average of around 980 hours. And when we break this down into different groups, we can see that licensed workers earn the most and work the most, while unlicensed workers earn the least and work the least. Compared with the private sectors, public sector workers earn $1 more on average, and they work roughly 80 hours more annually on average. So in the second table, we're looking at some estimated annual population employment We break these occupations down into two different panels. Panel A are occupations with high state variation in licensing attainment, and panel D are the occupations with low state variation in licensing attainment. For example, almost all states license lawyers, but for opticians, only around half of the states licensing opticians, while the other states do not. So we can see that social workers has a rather high employment base of around 1.2 million employment. And the lawyers and registered nurses have even larger employment base of around 1.5 and 5.2 million separately. Given the audience, we can see that economist has only around 70,000 employment base, and economist is a job which has a low license share, and most of the economist job is in the public sector. In terms of the identification strategy, we use a method from Auster 2019, which is first established by Altonji, Alder, and Taber in 2005. So we set up first we set up a two-week fixed effect regression, and other than estimating the coefficients of our treatment variables, we also want to estimate the relative degree of selection on all unobservables that would result in the true treatment effect of being zero, which is our delta here. And the logic is that we want delta to be large enough so that the unobservable is not a threat to our identification strategy, to our model. And when we set delta equals to 1, we can also estimate the bounds of our estimated treatment effect using different values of Rmax, we will show those different values of our Rmax later in our results table. So first, the first result here is how licensing would affect workers' choice in the public sector. And we can see that from column A to column E, we're gradually adding control variables into our regression model. So column E is the fully controlled model. And we can see that from column A to column E, the R squared is increasing while the magnitude of the coefficient is decreasing. And generally licensing has a positive effect on workers' probability of choosing into the public sector. And in column E, this effect is around 3.9%. And we can see that when we choose our Rmax to be equal to 0.47, our delta here equals to 4.3. That means that the unobservable characteristics in this model need to be 4.3 larger than the observable characteristics for the true treatment effect here to be 0. Therefore, we consider 4.3 is a quite large number that our model does not suffer from severe unobservable bias. Similarly, we are using the same kind of approach to present the results of how licensing and working in the public sector would affect our labor market outcomes here. And we can see that licensing has generally a positive effect on wages, around 6.6%, and licensing also has a positive effect on total weekly hours worked, around 3.6%. Working in the public sector, however, has a negative wage effect compared with the private workers. People who work in the public sector earn around 5.3% less. However, working in the public sector does not have a significant effect on hours worked. And in terms of our the effect on employment, because we're estimating employment at the state and occupational level, therefore we do not gradually adding individual characteristics into our regression model. And here we find that licensing has a negative effect on employment, and this the magnitude is around 34.7%, and public still does not have any significant effect on employment. So the effect of licensing here is comparable to the literature. So in the literature, two papers, Kleiner and Sodas in 2019, and Blair and Chung in 2019, find that licensing has around negative 29% negative effect on employment. So this number is comparable to what we have here. So next, we're looking at some subgroups results. First, we're looking at how licensing's effect on labor market outcomes separately in the public and private sector. We can see that the magnitude and the sign of our coefficients here are comparable to that in the whole sample, that licensing has positive and effect on wages and hours worked, while negative effect on employment. However, here that in the public sector has a larger magnitude for the positive hours worked effect, and in the private sector, the magnitude for licensing effect on employment is way larger compared with that in the public sector. It's around 20% larger. And note these three coefficients of licensing effect in the public sector, because we're going to use that to construct our welfare analysis a few slides later. So the second, we're looking at how public can affect labor market outcomes separately in the licensed and unlicensed group. And we can see that public still has negative effect on wages. And however, the magnitude of the wage effect is smaller in the unlicensed group compared with that in the licensed group. In terms of hours worked, recall in the whole sample, working in the public sector does not have significant impact on total hours worked. But here we have significant impact, but the sign is indecisive. It's positive in the licensed sector, in the licensed group, while negative in the unlicensed group. Working in the public sector still does not have any significant impact on employment in both licensed and unlicensed group. So when we're interacting licensing and the public sector together, so we're comparing licensed public versus unlicensed private and licensed private versus unlicensed public. We can see the coefficients, generally the magnitude and sign mirrors that of the licensing effect, that positive effect on wages and hours worked, while negative effect on employment. Therefore, we conclude that licensing, when interacting with working in the public sector, licensing effect takes the dominant role.
So Wenchen, you need to wrap up in a minute.
Yeah.
1 minute.
Yeah. By using the coefficients we derived from a licensing effect of working in the public sector, as well as using some numbers from Bureau of Labor Statistics, as well as making some assumptions for labor demand elasticity, we can make the calculation for the welfare effect of licensing in the public sector. We find that the annual cost to the public of licensing in the public sector is around $18 billion, while the percent change of the welfare effects for licensing in the public sector is around negative 23%. So licensing in general results in the welfare loss. So our conclusion here, licensing is positively associated with the probability of being the public sector, and this effect is around 4%. Licensing generally has positive effects on wages and hours, while negative effects on employment in the public sector. Licensing approximately results in an $18 billion annual cost in the public sector and a welfare loss of 23% for the licensed part of the public sector relative to no licensing in the public sector. And the baseline results are generally consistent with the economic models we listed here, and they are robust across different subsamples. So that's my whole presentation. We welcome any comments and questions. Thank you.
Thank you. And we're going to go right to Darwin Deo for her discussion.
I'm just waiting for, I think I can't share screen. Oh, there I can. I can stop the other one. Okay. All right. So I know I have 10 minutes, but we're probably going to be able to reserve some of that time to other questions and comments, just because I like having a conversation with people. So I'm going to check my time. All right, so I got to discuss this very cool working paper, and I'm happy to, I'm sharing my slides obviously in my notes, but I'm happy to keep talking about if any of this wants further clarification. This paper does address an important gap in the literature when we think about private versus public licensing of like how it affects certain factors like employment, earnings, hours worked, and also social welfare effects. And so there's a lot of heavy lifting going on in this paper. So one of the suggestions at the end is possibly considering whether or not this is actually two papers. It's always good to consider whether or not there's actually two papers lurking inside one paper. Or if, there's some possibilities for, and when I was a journalist, it was always, if you can write a paper or one article, you can write three. So that's a little bit what I bring to academia. So I have a bunch of suggestions. Feel free to take it or leave it. These are all just as I was working off of the draft. I know you may have some additional robustness checks and things like that in a different draft. So if you've already addressed this, cool. If not, let's talk about it some more and think about where we can go with that. So one of the things that I noticed first off was the framing of the paper. When you're thinking about how you're motivating this, what's the real outcome that you're focusing on? Why does it matter? And making sure it's clear to everyone, like what the study level is. Like, are you looking at occupations overall? Are you looking at individuals? You're looking at individuals. So like making sure like all of that framing is up there from the start. And then thinking about the economic choice model here, right? Is this about the choice of individuals to work in the public sector versus the private sector? Is this about the choice of individuals to become licensed or work in a licensed occupation, either staying in the public sector and say, hey, I'm going to go in a licensed occupation or not? Thinking about the significant differences between public versus private sector here. So saying like, is it like, yeah, we can say like, here's what the earnings are here, but like between the samples, how significant are those differences? That may be in another version of the draft of the paper that I don't have yet. But at the end, you then bring in the social welfare effects piece. And very important, love a back of the envelope calculation on the costs and benefits of a policy. But it sort of comes in at the 11th hour. So thinking about that, like as maybe introducing that earlier in the paper or using that to motivate the paper from the start would be possibly helpful. And this is where you just get the discussant who has too many ideas and just shares them all with the class. So a couple things off the top of my head were you've got licensing as a proxy for, risk aversion is doing a lot of work in the model. So thinking about like, what's the motivation for that? I think there's a few citations on that, but making sure you're like motivating that clearly, because there's a little bit of the piece where you're thinking about, you're looking at the choice for public versus private sector. You're looking at the choice to be in a licensed occupation or not in the public sector. So then saying that licensing itself is the proxy for risk aversion sort of is like answering your own question, or like, you know, sort of doing the double counting piece, not double counting, but thinking about like you're trying to address, like baking the answer into the question that you're asking. So making sure that like there's a strong foundation for that piece, because I think that would run into a lot of conflict if somebody was like, hey, where does this come from? How do public sector unions factor into the findings? Unions and public budgets, which I bring up at the end of the slide, major factors for how earnings are going to differ in the public sector versus the private sector. What about the shares? So you look at the share of licensed versus unlicensed, you look at public versus private, but the public sector has a much higher share of unionization than the private sector. And there's licensing within unions now. So there's a lot of stuff that you want to be accounting for. You're talking about this piece of, well, we've accounted for the fact, like the unobservables would have to basically be explaining 4 times as much variation. It's possible unions and budgets could explain that much, right? Like if you're thinking about what kind of public occupations you're looking at, which I'm going to get to in a second, like that could be actually very important. Thinking about the occupations that are in this sample. So you use this sort of catch-all of public sector. Is it federal, state, local? Is this like public agencies? Are you counting education in there? You've got economists in your nice little table of like different occupations. Not usually the example I would jump to when I'm thinking about licensed occupations in the public sector, right? I mean, it's fun for the AEAs, but like when we think about like the ones that are most likely to be licensed, what are those? What's the share of those? Well, like give some descriptive stats on what those occupations look like in the public sector versus private sector, because that would be in the CPS data. All of that stuff is, you know, there's plenty to go in on there. But I also think the public budget and financing issues would be relevant here when thinking about earnings and the employment of people. So we have someone on this Zoom session who's an expert on public economics. I think we have more than one, but thinking about like, where that factors in, right? That's going to matter depending on the occupations that you actually look at. Especially like if you're thinking about teachers who are licensed, and if they're included in your public sector piece, that's going to matter a lot, right? If you're talking about economists being, when you say economists are mostly in the public sector, is that census? Is that education? Like just making sure you have some descriptive stats to motivate like where you're coming from, I think would be helpful on the framing piece. And so this is where I just was running out of space on slides, but I think it's a really important piece of research, right? This is a question that needs to be addressed. We can now address it with the CVS data. Cool. You fly over the like sort of all the data work you do very quickly, both in the slides and the presentation. There's a lot that you've done there. That's hard work. And there's like important stuff there that we can really learn from as a profession. And like, it adds to the stock of knowledge. So I think it's very important. But also I look forward to seeing the next draft of the paper down the road. And I'm going to reserve the rest of my time for questions.
Fantastic. So I think I'm going to ask Ed and then Alicia to ask their questions. And Wenchen, if you can keep track, you could maybe respond to both at one time or just clarify. So go ahead, Ed, and then after Ed, Alicia, just jump in.
Thank you. My question just was, would it be possible to produce back of the envelope costs on a state-by-state basis? The overall estimate's great, but it'd be nice to see that on a state-by-state basis if possible.
Do you want me to take it, Professor Kleiner, or do you want to?
Let's let Alicia get her question in, and then you can go ahead.
Oh, mine's more of a statement than a question, which I guess we've all missed hearing that at conferences. It's just, I've been working on some public sector work lately, and I've realized one thing that might matter for your data, at least as a control, is some states have very weird requirements for licensing boards that are administered through unions for public facing jobs. So like public related government jobs. And some of them require either a government official to be on that board. Some of them require like a disinterested third party to be on the board. Some of them require like that practitioners need to be retired. So I would look at what the state differences are into what the licensing boards administered by public unions within those states, how they differ, just because I've run into issues on a different paper on that difference.
Great. And Wenchen, if you want to go ahead, respond, either to Darwin or to your questions, that'd be great.
Okay, yeah, so I think in terms for Ad's question, yeah, definitely, like we can do the back of envelope calculation for each state, and I think that's actually a good advice to include in the paper, so we can see the welfare difference across states. And in terms of the Alicia's comment, yeah, I didn't know that was the case of like public sector being administered through unions, but I think when for my controls, I'm not adding licensing requirements for now, but I will. So like that's a good control to include in the along with the licensing requirements.
Yeah, I just think on that point, and this might just be interesting for you to be able to see, because I think it'd be an interesting result as well, is that with some of those differences, I've realized when there's a lot of third parties that are also included on the board, or there's a lot of government officials that are included on the board, not just practitioners that are actively practicing. It seems to me like the costs are a little bit less and the wage differential seem to be a little different, but I obviously can't really speak to that at this point, but it might be interesting for you to see.
So it's just one thing. So when you're saying that the licensing board administered through unions, are you talking about like other than administered by the
sure.
board?
So this is teachers, this is police, this is firefighters, this is most electricians that are done through the public sector. So all city governments, all state governments happen to have city level officials for electrical. Plumbing, a lot of the time actually has state level licensing, where the public union for plumbing within those states have to be administered through the union, and through the union we end up having this other piece happen where they say, okay, well, depending on what state you're in, there might be requirements on who needs to be physically present on that board. But I didn't mean to get off into a tangent. I'm so sorry about that, Wenchen and Morris.
Yeah, just one quick thing on the union issue. The effects of unions in the public sector is very similar to the effect of licensing. So that would be sort of, and one thing we would probably look at is the interaction effect, which we've looked at in other papers, but certainly the union times licensing effect, we would expect would be even larger.
Fantastic. Okay, so I am going to move us to our next presenter, Alicia Plemmons. And why don't you put your slides up? And while you do that, I will mention one other logistics thing, which is that I think one of the great advantages of virtual conferences is that we can all put questions and comments in the chat just at will. And that's very helpful for presenters. Even if we can't get to every one of them in discussion time, all our presenters can copy those down and take them back. So don't be shy, put questions and comments in the chat. I see one more came through for Wenchen, and so that's great, keep that up. I will now turn it over to Alicia, and then that will be followed by discussion from Ilya Kukayev. Go ahead.
Hi, everybody. For anybody who doesn't know me, I'm Dr. Alicia Plemmons. I'm at Southern Illinois University, Edwardsville. I'm going to try to keep you interested for the next 15 to 20 minutes. It's very hard to follow Wenchen and Morris, who have done such fabulous work in the space, but I'm going to try. I'm going to move it more towards the healthcare side and talk a little bit about scope of practice and opioid prescribing behaviors of nurse practitioners serving Medicare beneficiaries. This is a topic that's been popular in the scope of practice literature, which for anybody who doesn't know, scope of practice is what we've sort of seen as the subset of healthcare related licensing. That's not only the necessary question of can you work this job or not, but what can you actually do with that license? Are you able to prescribe medication? Are you able to treat patients? Are you able to make diagnoses? So looking at this relationship in between scope of practice for nurse practitioners, what nurse practitioners are allowed to do, and if they're allowed to prescribe medication, how those outcomes are related to opioid use and opioid prescribing patterns, because it's something that's just been important in the literature right now. So if you see the number of slides on the bottom and you're freaked out, don't worry about it. I actually have a lot of pretty pictures for you. So we're going to go through and see if I can at least keep it a little interesting following such a good presentation. Now, I don't think I need to talk too much about the institutional background, because I noticed that most of the people who are here either work on a licensing paper or are a licensing related economist. So we'll just keep it brief. An occupational license, in case you do not know, is a required government permission to work within a certain job, right? This is the idea of being an electrician or a truck driver or a medical technician. 22% of the jobs in the US workforce require an occupational license to do their job as of the BLS in 2019. I'm sure that that's been different with some of the changes that we've seen in the labor market during the COVID-19 pandemic, but this can be a substantial cost consideration for firms. Licenses, it turns out, are sometimes difficult to get. You have fees, you have examinations, you have lots of time for education and experience training. So thinking about these substantial cost considerations is really interesting. When it comes to healthcare specifically, it's really important to note that the US is facing a massive primary care shortage. I think it's expected to be roughly what I think it's 25,000 physicians in the next few years that we're necessarily missing to be able to provide adequate care, going up to about 150,000 physicians by 2030. That is a substantial amount of missing primary care for individuals. Well, primary care in each state slightly differs. It's not always just someone who has an MD. A lot of the time, in certain places where it's allowed, nurse practitioners actually serve a role for giving primary care. Nurse practitioners are advanced registered nurse practitioners, are nurses who have gone through substantial training. They've gone through additional education, additional experience. They've spent more time in clinicals. They've spent more time in the classroom. They've spent years and years beyond what we would have for registered nurses or something like that. And instead have gone to the point of being considered experts in their field in certain places, right? So the field defines a scope of practice for what these nurse practitioners are allowed to do in between each state. And we'd like to break these up into two main categories. First is the scope of practice, what people are allowed to do. So are you allowed to treat patients? Are you allowed to see patients? Are you allowed to be a primary care provider? And then prescriptive authority. Are you allowed to prescribe Schedule 2, 3, and 4 medication? So the differences that states have end up affecting many different types of practitioners who fall into these categories, whether a pharmacist can prescribe medication in needed situations, whether a certified nurse midwife is able to see patients immediately. What we're going to do is focus on the nurse practitioners, but there's a lot of different elements to this that are important. I want to preface this discussion by first talking about the core healthcare problem, because it relates to what's happened so far in the literature. At the end of the day, our goal for healthcare policy is to increase access, increase quality, lower cost. And we would love to be able to do that. The problem is that each of these pieces are dependent on one another. When you increase access, many times quality goes down or cost goes up. When you lower cost, you might have issues when it comes to quality or the access element. So when we're thinking about balancing this relationship between quality, access, and cost, it's really important to think about what's happened in the literature so far. In the scope of practice literature, we found that allowing nurse practitioners to have full scope of practice and to prescribe medication is crucial for providing access to rural communities for healthcare that they may not get otherwise, or to low-income neighborhoods or other socioeconomically marginalized communities. It also helps lower costs. Nurse practitioners bill at 85% of the rate of physicians. So if this is a way to increase access and lower cost, the main concern is quality and safety. If nurse practitioners have the right to prescribe medication, what does that mean for the way that they prescribe? Are people going to be getting the adequate amount of medication? Is it going to be too much? Is it going to be too little? Could this further the opioid epidemic? There's so many questions that we have here. And I think that this has been the real stopping point for some of this policy work, is thinking about, well, what's happening with this quality concern? So one way to expand access, again, is to allow nurse practitioners to provide primary care, but we're going to look at the differences in between. And it's very important to notice the two: the scope of practice and the prescriptive authority. So the roles and duties that the practitioner is allowed to perform, and the ability to prescribe medication. Because it doesn't quite matter if you're in a state, in a rural community, where you can be diagnosed with something. If you need medication to be able to take care of your ailment or your injury, and your nurse practitioner is not able to provide that, then you still have a lack in being able to have some of this health care. So I'm not going to go through all this, because many of the people who wrote these papers are sitting here on the call, and honestly, they've done a lot better work than I have. But there's a lot of benefits and a lot of costs to the idea of scope of practice expansions. Some of this is the idea of increasing the supply of primary care providers. Patients tend to have more face-to-face time with providers when nurse practitioners are on their care team. They're more likely to stay on medication and treatment plans because there's more of this face-to-face interaction, and there's cost savings, especially if in retail clinics. But there's a lot of cost too. When we're talking about not necessarily routine medical care, but more rare medical issues, nurse practitioners tend to order slightly more tests. They take longer to diagnose rare or extremely complicated ailments. And there's been some pushback from the American Medical Association, as in this is sort of, they're concerned that this might eliminate physician jobs. So going from there, we wanted to address sort of the opioid debate. So this is something that the American Medical Association has highlighted that they're afraid of if nurse practitioners were given the right to prescribe medication in all states. They think that it might further the opioid crisis. That's a totally reasonable concern that needs to be discussed and needs to be measured within the literature before making policy change, which I think is why we started to come to the conclusion that this is something we needed to look at. Because policymakers have been hesitant to expand scope of practice for nurse practitioners because they're concerned about this potential overprescribing of medication when the practitioners are completely unsupervised, which means that there's not a physician within the same building or who collaborates with them going over their case notes or anything like that. And I think the literature has struggled to completely address this concern. So there's been many papers on the relationship in between scope of practice and opioids. And they use large panel data sets. They provide that are provided directly from hospitals and government. They've been peer reviewed. They've been published in major outlets, and yet these papers have still been getting a lot of pushback in the literature and from policymakers. So Shishir and I, which I should have mentioned him earlier, Shishir is my fantastic co-author who I get to work on this with, who's one of my favorite people to work with. We started going through the literature that was very critical of these scope of practice expansions when talking about opioids, and we wanted to look at why were they getting pushed back. Well, we figured out that some of the issues was that there was no consideration for legal differences between prescriptive authority and scope of practice. It used to all be branched into one word, just scope of practice, one term. It wasn't until the recent work of Sarah Markowitz and Ben McMichael, who were really able to go through the legal definitions of every single state to finally split the two, where we're able to know for each state what really is the status of prescriptive authority and scope of practice. We also noticed that there was a lack of policy variation during the sample period and a lack of strong causality arguments. So we wanted to come up with a very unique and interesting way of thinking about the question, do nurse practitioners change their prescribing behavior when they are unsupervised?
So Alicia, I just want to make sure you know you have about 6 minutes. So
oh, don't worry, we're going to get through it. I probably spent way too much time at the beginning, but we got this.
Good.
If we want to talk about the data later, feel free to talk to me about that, but we're going to be using the Part D prescriber summary tables and the MPI registry. Basically what we did was we found every single nurse practitioner, found their location, specialty, and prescribing patterns, and we're able to match that with some records of what's happening with Medicare beneficiaries. To circumvent the variation problem, the fact that there's not much policy variation during this time, we actually thought of a really unique and interesting way to think about this. And it's the fact that we have two real elements. We're wondering what happens when people change their when the scope of practice changes. So there are some states that allow for people to prescribe medication supervised under restricted scope of practice, while there's other states who allow people to prescribe medication under a full scope of practice. So what we wanted to see was when people migrated between the two, when they might have changed states for some unrelated job reason, what's happening to their prescribing pattern when all of a sudden either their state changes or they themselves have moved to a different sort of state under a different regime. Do they act differently in their prescribing behavior? So now that I'm running late, don't worry, we're just going to go past some of these, but we started thinking about this mobility element where we have a comparison group of people who move from restricted states to other restricted states, and we compare that to people who move from restricted scope of practice states to full scope of practice states. All of these people have the ability to prescribe medication, but we're interested in the ones that are moving in between the two. So we use just a simple difference in difference. This is one of the few times we still can, which is really interesting because I'm sure everybody's exhausted with how fast difference is changing on Twitter. But because we're using a series of 2-year cross sections where we see people moving in between 2-year periods, we're able to look at their before and after behavior. So this is just an interesting null results paper that kind of talks to the literature of what's happening. We found that when these people moved, and we looked at people who moved to full scope of practice state versus restricted states, that had always had prescriptive authority, we found that claim counts were different, drug costs were the same, days supplied were the same, beneficiary counts were similar, prescription rates were similar. Then we decided, okay, well, instead of just immediate opioids, let's look at long-acting opioids. We found the same thing. There was no real differences in claim count, drug costs, days supplied, beneficiary counts, prescribing rates. So then we decided, let's bring it back and not just do opioids. Let's also look at other things, antibiotics, branded drug medication, generic drug medication. At the end of the day, we found no real differences. But we need to ask, is this a null effect? All the other papers in this literature have gotten this far. They found that they've had this null effect. We wanted to test the validity of if this is actually a null effect. So we did 4 things that I think are important. We had a placebo test that randomized the treatment assignments. We just randomized for different people what their treatment was. We had a placebo test that randomized the population assignment, so what population they were in. We looked at the policy reversal, so people moving from full scope of practice states to restricted scope of practice states that still had prescriptive authority. And we incorporated many different types of covariance and threw a battery of tests at this. So when we permutate treatment running 1,000 iterations, what we end up finding, and I know this is a lot, let's talk through it, is the fact that R0 was different from a just randomized 0. As we see for each of these different distributions, these distributions represent what would be a randomized 0. The dotted line that's most often to the right, but sometimes to the left, that's the 0 that we find. We find that the effect that we are finding cannot really be done by randomized chance. It's extremely unlikely that this null effect that we're finding is actually just noise. From there, we went ahead and also did 1,000 iterations with changing the scope of practice within different states. And in this case, we If this were a true null effect, we would expect to be in about the center of the distribution if we had randomized the population. We see that that happens to be the case where our estimates are about right where they would be if we had randomized the population, under what sort of regime these different people who had the ability to prescribe medication, whether they had full or restricted scope of practice. From there, we also looked at policy reversals. What happens when we have people who they've been able to operate and prescribe medication on their own for a long time, and then all of a sudden we're comparing the group that moves to another state where they continue to do that compared to those who now have supervision or collaborative agreements while prescribing medication. Again, we found that there was no real significant results, then there was no real difference in behavior. So we failed to find any significant evidence of expanded scope of practice on affecting nurse practitioner behavior. Again, we have other things that we've started looking at that we think are interesting, looking at people working within hospital and non-hospital settings, so also considering retail locations, physician assistants, incident to billing, which we got to call and email CMS a whole bunch of times to talk about very specific pieces, and we think we actually have some cool results when it comes to incident to billing. But at the end of the day, what did I just show you? I showed you that we're talking about a policy change that the literature has found increases access and lowers cost, and we wanted to think about what's happening to quality and safety in the opioid epidemic. What we find is that when nurse practitioners end up moving states and the policy that they are operating under is different in their scope of practice, but not in their prescriptive authority, their behavior doesn't change whether they have that supervision or collaborative agreement or not. They still prescribe the same way, which speaks to us to say that quality is not necessarily a concern when it comes to the opioid epidemic, which is very interesting because there's many states right now, especially with COVID-19, that temporarily expanded scope of practice, and some states are restricting that again, while others are considering keeping permanent expansions to scope of practice. I think that this paper really speaks to some of the concerns of legislators of why they might be worried about expanding scope of practice. And we want to say that when we do a battery of tests at what the literature has found, when we really focused on having good mechanism design and we really focused on thinking about these causal relationships, we find no evidence of scope of practice expansions leading to an overprescription of opioids by nurse practitioners. And with that, thank you so much. I still have 5 seconds left, so I think I'm doing pretty okay, but thank you everybody for coming and talking about this today. And I guess I would pass back to you, Abby.
Fantastic, thank you. And now we'll go to Ilya for discussion, and I'll encourage folks to put questions in the chat as well so that we can ask a couple of those during question time. Go ahead, Ilya.
All right, thank you very much for giving me an opportunity to discuss the paper and be part of that great session. So I'm discussing scope of practice in opioid prescribing behavior of nurse practitioners serving Medicare beneficiaries by Shishir, Shakya, and Alicia Plemmons. Before I start discussing that, I just wanted to draw your attention to one thing that I noticed last year in August. There is like this Chicago Booth service prominent economists on their opinion on different things, and one of the topics that came up last August was occupational licensing. So occupational licensing reduces mobility, that was the question, and wages for workers in many sectors where they could safely deliver services that consumers would prefer to those offered by licensed workers. And there's like a great consensus that this is indeed the case. So I was just happy to see that the occupational licensing attracts attention even in that survey. All right, so this paper is about opioid drugs and nurse practitioners and their scope of practice. So basically there is this opioid problem in the US, and as you can see over time it's growing. The most driving factor, or the dominant factor in those opioids are synthetic opioids, in particular this opioid. So perhaps in your paper if you can distinguish between those like opioids and this particular synthetic opioids, that would be great. The next maps I think really highlight the importance of the topic that the authors are looking into. So this is the drug overdose deaths in the US per 100,000 people. So those are mainly concentrated here in the East Coast. And if we look at the drug overdose deaths in local areas, so those are the areas where that opioid kind of epidemic is going on. And then if we look at the nurse practitioners and this regime of full practice authority, we get this map, which is the green states are the states where nurse practitioners have this full practice authority. So the epidemic is going on here, and the full practice authority states here. So I think it just again highlights that full practice authority might not be contributing to that opioid pandemic. So what's the summary of the paper? Full prescription authority doesn't change prescription behavior of nurse practitioners in terms of prescribing medicine, and in particular opioid drugs. That's the message. So here's the like my intuition of the paper. So if we have, this is just a simple model of production. On the left hand side, we have this healthcare production of prescribing opioids, prescribing any other drugs, diagnosing tests performed by practitioners. And in labor, we have doctors and nurses. And in the restricted states, this alpha is 0, and only doctors can prescribe opioid and prescribe any drugs. And in the full practice authority, that alpha might not be 0. So if we plug in this thing into the production formula, we get this result. So the authors are basically asking whether this effect of full prescription authority have any, like, is there an effect on prescribing behavior of any drugs? And they basically claim in the paper that in restricted states and the full practice authority, they are basically the same in that regard. So why is this paper important? So full prescription authority has pros and cons, and if cons minimized and not detected, then pros outweigh the cons, and policy has potential to be adopted to increase access to health care. So one of the unique aspects of this paper that I really enjoyed is a clever identification strategy. So there were a lot of diagrams in the presentation, but the main idea is basically the authors are not looking at the changes in policy regimes across states. They're looking at the nurses who migrated from one policy regime to a different one, to the full practice authority, and they compare control group versus treatment group. So that's a clever identification strategy of that paper that I particularly enjoyed. So what are the suggestions to improve that paper? So the first thing that the authors assume that those nurses that migrate to different states, they kind of like the same. They say that the nurses migrate for family reasons. So in general, perhaps you might consider thinking about selection bias. Maybe nurses are not the same when they migrate to different states. Maybe you can use something like inverse Mills ratio to check for that particular potential selection bias. Another thing that you might consider to improve the paper is to implement propensity score matching, or any type of matching. There's this paper that kind of criticizes propensity score matching and proposes other types of matching in a different deep setting. So you might consider that as just a robustness test. Another question that I had when I was reading the paper is, so you cluster standard errors of nurse practitioners by specialties, and I was curious, how many specialties do you have in your data? So I checked briefly in the internet, so there are like at least 10 or 13 specialties of nurse practitioners, but I think for clustering you need at least 30 clusters. So maybe you could emphasize that in the paper more clearly. Another thing that you might want to consider is this log of y+1. Maybe you can, as a robustness check, so that's log of y+1 is the left-hand side variable, and clearly this is done because you wanted to, you had zeros in your data, but you might consider other approaches like trimming the lower tails, for example, or even better, instead of a log transformation, you might consider inverse hyperbolic sign transformation for your left-hand side variable, where you can preserve zeros and not generate a data that's not there. You can particularly refer to that paper that talks about inverse hyperbolic sign transformation. Some other questions that I had when I was reading the paper, I was wondering if you have data on whether nurse practitioners diagnose patients. So full practice authority, it's not only prescribing drugs, but it's also diagnosing, running diagnostic tests. on patients. So I expect maybe there might be some difference between whether nurse practitioner takes the first visit and diagnoses a patient, whether the nurse versus when nurse practitioner takes the follow-up visits and already on already diagnosed patients. If you have that data, maybe you can compare those two, the first visits versus follow-up visits. I was also curious what's the mean age and age range of patients in your data, and can the results be extrapolated on younger age groups, because the opioid pandemic is happening for the middle age and younger age groups. And I was just curious if you can find some positive effects when the nurse practitioners change the regime. For example, is there increase in healthcare utilization? Is there increase in diagnostic tests, or waiting time, or maybe waiting times are down? So the paper would make a stronger case if the analysis picks up some changes between regimes, but those are unrelated to opioid prescription. So on the website of Nurse Practitioners Association, they state that in full practice authority states, the nurse practitioners are more likely to practice in rural and underserved areas. So perhaps you can look into those and just see some positive results as well. So that would make the case stronger, that your analysis picks up some positive effects. And here, I was curious, maybe you could in the paper emphasize more, maybe add a paragraph how you compare your results with previous findings where there have been some findings that the opioid prescription behavior changes. So perhaps you just can contrast your approach to previous literature more clearly. So
and Ilya, just 1 minute for you.
Yes, I'm almost done. So the diagrams can be drawn in LaTeX, and I think from your presentation they are drawn in LaTeX, but in the paper they look like they're just excerpts from some. So they don't look like they drawn in LaTeX in the paper. So I was I wanted to recommend these packages to draw these diagrams, and the font size was too small. I don't know, just maybe you can fix that for the future. But thank you very much for your attention. It was great to read that paper.
Awesome. Thank you, Ilya. So I think as we did, I will call on one or two folks for questions. And then Alicia, if you'd like to respond to Ilya or any of the questions, that would be great. I have a question myself. I'll ask that. And then Ting Ting also has a question. So Ting Ting, you will be up next to ask your question. The question I had was just how do state level regulations on opioid prescribing overlap with the regulations that you're looking at? So that's something I know less about, but I had the impression that states also differ in the registries that they have of opioids that get prescribed out and other tracking mechanisms that they have for providers. So just that was a question, was kind of how those other regulations might intersect here. Ting Ting, you want to go ahead?
Yeah, thanks. I just kind of probably missed that part or wasn't really clear about that part. So I wonder how long does it take for people to change their behaviors, right? If your data just saying that we compare a year before the move to a year after the move, maybe people are not responding quickly enough. So is it possible, if you can add additional kind of a period of learning or adjusting? I don't know. It just seems like it's a fascinating result, but in some way that how can you kind of strengthen that result, right? Thanks.
And I want to give Kyle a chance, who added a good question in the chat. Kyle, do you want to go ahead and ask your question?
Sure, thanks. So I was curious, so I went and looked at the map that was brought up by the discussant, and those yellow areas that indicated some degree of restriction for NPs. I don't believe that necessarily means that those NPs have to be in a collaborative agreement with physicians, and that might allow NPs be in collaborative agreements with other NPs. So I wanted to ask about that. And then I wanted to ask this broader question about whether or not NPs change behavior, if that necessarily guarantees that the overall number of opiate prescriptions is going to change or stay the same.
Super. So Alicia, if you want to take 2 to 3 minutes just to respond to whatever you would like to respond to, go ahead. It's your choice. And then we'll go to Bobby.
So by the way, thank you for the discussant comments. Those were wonderful. I'm going to follow up with you by email with those because there's a lot of things I want to talk to you about, but I'm going to go through the questions. So if I got the first one right, Abby, you're asking about how do other state level regulations overlap? A majority of the prescription monitoring regulations came in before our sample time periods were already established in states and didn't change too much over this period, but we do have different levels of controls that we have in the additional covariates to account for those differences. Ting Ting, I don't believe so. So the year-to-year lags, we've also looked at longer year-related lags. So thinking about what their behavior would be 2, 3, 4, and 5 years afterwards. The problem is as we do that, the sample size starts to get much smaller, which means that we start to worry a little bit about the robustness of our results when we start having smaller sample sizes. But the relationship appears to be consistent at 2, 3, and 4 year lags. Kyle, so looking at the green, yellow, and red states, the definitions that we use were the ones that are put together by Sarah Markowitz and Ben McMichael. Ben McMichael is a lawyer over at the University of Alabama. Sarah she runs parts of the Health Policy Center over at Emory. They together had a team of lawyers who went through the books in every single state to be able to figure out when these collaborative and supervisory agreements were required to be with a physician, and we used those definitions in this. So when the collaborative and supervisory agreements had to be with a physician. So we did make sure of that one when doing this, because that was in the definitions that we had available. A lot of the time what these restricted states are, so we have 3 different types of states, and I probably should have gone through that a little slower. There's full restricted states. Those are the ones where there's no prescription authority and there's no scope of practice. We didn't even look at those or consider those because we're looking at differences of people who have prescriptive authority under different collaborative and supervisory agreements. Instead, what we did was we looked at the set of states where there was full prescriptive authority with the supervision and supervisory or collaborative agreements, and those states who did not have that element and there's full scope of practice to be able to diagnose things. So I think all 3 of those are extremely good questions, and they're things that we need to make much clearer in the paper. So thank you all for that. I also want to go back to, because I think I have a minute maybe, but I just wanted to go back to the idea of thinking about, is the representative sample of nurses leaving a state similar to is it a representative sample of the state itself? I think that that's a really great point that we haven't properly addressed within this paper, and I'll be sure to going forward. So thank you for that suggestion. All right.
Fantastic. Thank you, Alicia. Thank you, Ilya. So we are going to go to Bobby Chung next. Bobby, if you want to put your slides up, that would be great. And I'm just going to mention to folks that Maria Comumenta couldn't join us today. She is ill, as so many folks are right now. And so I'm hoping we can really crowdsource this a little bit for Bobby and be particularly helpful putting questions and comments in the chat. Bobby, you'll have 20 minutes. We'll give you a little extra time, but then after that, I will go to questions in the chat. Go ahead when you're ready.
All right, so can you guys hear me and
Yep.
also see my screen? Okay, thank
Yep.
you. All right, good morning to most of you, and maybe good afternoon, good evening. So thanks again for Abby to chair the session, and thanks Morris for putting together such a couple of great papers together. And again, the great papers by Morris and Wenchen, and also great paper by Alicia and Shishir. So today I want to talk about teacher licensing using the recent variation of additional requirement called the TPA. So this is a joint work with Jian at the University of Illinois. So he is the graduate student and he should be on the job market next year. So keep a close eye on him. He's such a great co-author and also did lots of great work on peer effect education as well. So and also this great paper about licensing too. So circle back about this licensing paper about teacher licensing. So the first question is, why do we need to care about teacher licensing? Right? Lots of licensing in lots of professions. Why do we need to care about teacher licensing? It's because it matters for our next generation. Teacher licensure in US has been a primary policy, primary system to kind of guarantee teacher quality in the U.S. public school system. So in the sense that we care about our next generation, we should care about teacher licensure, whether it really achieved the intention. So same for other professions, teacher licensure requirements differ by states. It is quite hard to understand, but it is good for researchers because we have a good variation across states and also across time. So one common exam component in the current setting is the teaching readiness assessment. And since 2014, a number of states started to introduce ATPA and long-form educative teacher performance assessment to improve teaching readiness. So the argument is that in the old exam, we just use one-time written exam. And some of the educators argue that, hey, this is not practical enough. We should introduce some practical performance evaluation to try to improve further our teaching readiness. And so by 2018, 8 states have mandated this assessment as a necessary part for initial teacher licensure and program completion. And this is where we are going to explore the time and state variation in our study. So a brief background about ATPA, what it is. So this figure already tells the essence is to videotape your teaching. So and it's also interesting that if you Google or if you YouTube ATPA, lots of the video teaches the teacher candidate how to videotape ATPA. And so I think it's kind of the very hot contested area because most of the focus only talk about like how to videotape instead of really teaching performance or really teaching assessment or teaching effectiveness. So ATPA is a performance-based assessment taking place alongside with the teaching internship. So different from the one-time written exam, maybe you need to take like 2 to 3 weeks beforehand to prepare for the MC questions. This ATPA involves a kind of like several months preparation, even a year. It involves lesson plans, classroom videos, and detailed reports. And if you look at some of the course prep in some universities, they also teach you how to videotape, how to edit the video, things like that. Other skills that may not be helpful to in-person teaching. So it is now administered by Pearson. I think all of us are familiar with this this private company. So the score is based on 15 rubrics usually, and a total of 75 points. So for the states who implement ATPA, the passing score vary. So a common questions in the past asking like, do we find any effects when we try to explore the heterogeneity of passing score? And the answer is no. We try to look at that and we don't find any heterogeneity. So through the research, we just focus on 0 or 1 dummy, whether the state implement or not. And surprisingly, and overwhelmingly, a lot of the comments about ATPA is negative. Some of them talk about this is a kind of additional entry barrier, especially for teachers of color. And also some of the educators argue that ATPA just describes natural learning process. As I emphasized or like mentioned before, a lot of the tutorials teaches videotaping, video editing, but not the actual teaching techniques. So this paper examines the effects of ATPA on teacher supply and also the student outcomes. It's straightforward. And we think that we make a couple of contributions to the literature. So the first one is, in terms of the ATPA itself, it is the first attempt to offer cause and effect interpretation using a national sample of new teachers and students. In the past, most of the studies usually are just qualitative. Even it is quantitative, it is usually case specific or correlation or descriptive statistics. And second, broadly, we want to relay our study to the overall understanding of teacher licensure and also teacher shortage. A number of previous papers mostly focus on cross-sectional or descriptive statistics, and here we try to offer causal effects and also try to relate teacher licensure to teacher shortage. And lastly, we try to contribute to the overall welfare effect of occupational licensing. And we offer a comprehensive review of quantity as well as quality effect at the same time. All right. So this map just captures what we are trying to do in a different diff setting. Earlier, Washington, New York implement a TPA, and followed by Illinois, Georgia, and then Wisconsin, Oregon, and Alabama. Just one digression, in recent months, or actually last year, Georgia decided to revoke ATPA, just remove ATPA as a requirement. So I think there's a lot of debate whether states still keep going on or abolish it. All right, so we have two main sessions. The first one is teacher shortage, and the other one is student outcomes. Talking about teacher shortage, we analyze the iPad data. So the iPad data documents many detailed statistics about the number of graduates and also number of enrollments in the post-secondary institutions. And we are going to focus on post-secondary graduation in the education majors between 2011 and 2019. We dropped the optional states. I forgot to mention a number of also other states regard ATPA as optional. So in the main analysis, we dropped that, but in the robustness, we also added that back, and we show stable estimates as well. So treatment effect. So the treatment group include the 8 states I mentioned, and varying by the timing of implementation. Unit of analysis is the universities. So we are looking at a panel of universities, their number of their number of education graduates, do they drop or do they increase because of ATPA? So the outcomes is the log of new teacher graduates by race. All right, so this is just mathematically showing you the different div specifications. The ATPA dummy is the variables of interest. We control for many time varying university level characteristics, including their quality, including their size, including the resources, also including the financial endowment resources as well. And for sure, we control for institution and also time-based effects, and we cluster in the area at the state level. All right, so here's just a event study graph showing you that first of all we have a stable pre-trend, which is good for different setting, and then the negative effects start to show up in the first year and then start to grow a little bit when time passes. All right, so this table just shows you that panel A across different specifications, either we flow in trend or other controls, the effect is still stable. And we also alter the sample. We try to check the sensitivity. Again, the effect is quite stable between 11 to 15% reduction in teacher graduates. And when we separate the analysis by race, we also find similar effects. So here we don't find strong heterogeneity by race, but in the following, we are trying to look at the heterogeneity by type, and we see huge heterogeneity when we look at specific type of schools. All right, so heterogeneity, so the first heterogeneity I think is very interesting, and I think it's very coherent with our story. When we look at bachelor versus master degree, we only find effects on bachelor degrees, not master degree. And I think this is due to two reasons. First one, people who decide to go through master, they are more devoted and they are more committed. And so I think the additional requirement won't matter much. And second, some of the people who pursue master degree, they already passed the licensure. Maybe they are seasoned teachers instead of new fresh graduates. So either case, ATPA shouldn't matter for them, and this is what we find. Bachelor degrees are the major pool of fresh graduate initial licensure, and this is where we find effects. So in the following, we are going to separate the schools by several criteria. We are trying to look at whether the effects concentrate on less or more selective universities. We are grouping universities by their SAT and ACT scores. We also look at whether the effects concentrate on minority concentrated universities as well. So panel A and panel B showing you that. So let's focus on column 1. Panel A and panel B show that the negative effects concentrate on less selective universities. And this is true for white and both white and non-white candidates. When we separate further the race of non-white candidates, we find small effects for Black and Hispanic candidates. And we think that's one of the reasons because we are mixing bachelor and master degrees here. So what we do, and what we do in the appendix, we also show that when we just look at bachelor degrees, we also find very strong negative effects for both Black and Hispanic candidates. So this is the first takeaway. The second takeaway is looking at panel C. We categorize the institution in terms of the minority concentration. Column 1 shows that minority concentrated university have a bigger effect. The difference is not significant, but you can see that it's slightly larger. When we focus on specific race, Black and other race, they have stronger effects in minority concentrated universities. So here, in addition to documenting the equity issue, which is mostly complained by educators and also education researchers, I think one important takeaway here is if we think about intermediate solution, okay, instead of thinking about just abolishing, if we really want to keep ATPA, what is the intermediate solution? And I think the heterogeneity here suggests that we should provide support in a number of situations, including less selective programs, providing more support to minority candidates. And I think this is the valuable takeaway from this heterogeneity analysis. All right, so robustness, for time's sake, I want to skip it, but the main takeaway is that our result is stable, and also our variation is kind of exogenous. All right, so student outcomes. So I think this is very important because the first part, we document the cost of ATPA in terms of reduction of labor supply. We want to know, hey, is this cost worth, is the ATPA worth the cost? Because if eventually student benefits from better teacher training, then maybe we can consider keeping the ATPA. So the main challenge of evaluating the student outcomes is we have to find a common yardstick, because we want to generalize as to the national scale. So what we analyze is the NAP data. And
So
this
Bobby,
is
you have about 2 to 3 minutes.
Sure.
Just a heads
All
up.
right. So NAP data, so it's a restricted student level data. So it is not panel, but it is cross-sectional and it is nationally representative. So we are going to analyze the data from 2009 to 2017, and it is a biannual data. We are focusing on math reading score in grade 4 and reading score in grade 8. So sample selection, one unique feature about NAP is that we can identify new teachers by their years of experience. And so we are only looking at the new teachers. We also drop samples with teachers who have no certificates. Maybe they are joining the teacher force by specific program like Teacher for America or something. So those are not in the sample. We also drop optional states in the mini analysis. All right, so again, this is a standard div and div, but at the student level. All right, so here's the aggregate picture. We don't actually quite find effects, but remember, this is just a raw picture. We haven't flow in control yet. So what we want to show next is once we flow in control in column 3, 6, and 9, which is the full specification, we find negative effects for grade 4 students and not grade 8 students. So this pattern, I think, is very consistent with other education findings that younger students are more influenced by teachers, and you see that grade 8 student has no effect, and which is quite consistent. And also consistent with our previous finding, the effects only concentrate on teachers who went through traditional routes. Teachers who went through the master's degree won't have much effects on it. We also see some positive effects for grade 8 students, but it's quite sensitive. So we treat it as supplementary, not conclusive. All right, so further, we break it down by percentile. So here's a quantile regression trying to look at does the effects concentrate on a particular type of students, and we find that when we look at the grade 4 students, the negative effects concentrate on high achievers. So again, robustness, I won't go into details. We can look at it if we have time later. So mechanisms. So one last thing we want to do, we try to understand why ATPA cause negative effects. So we test a couple of things. One consistent pattern is the last column here, large class. So when we look at grade 4 math and grade 4 reading, both we find is that the new teachers are more likely to teach large class. And I think this is very consistent with the teacher supply story. We have fewer new teachers, so the new teachers are more likely to teach large class. Workload are higher, and teacher quality goes down. So this is one possible explanation. We are not saying this is exhaustive, but here we are trying to make use of what we have in the data and try to explain what happened. And I think this is a conclusion. And yeah, thank you for your attention. And thank you. Yeah.
Super. Thank you, Bobby. So we do have a little bit of extra time for questions. I think that we'll just follow the same format, which I think is good, but maybe I'll take a batch of questions, and if people put more in the chat, we'll come back to those as well. So I'll kick off with my question, and then I'm going to ask Mark to ask his question. And then Bobby, I'm going to let you answer those quickly, and then we'll come back to a couple extra ones in the chat. So my question is, I really had two. One is about the magnitudes of the supply effects. They seemed large to me, but I was wondering if you could talk a bit about that. Maybe I didn't have the left-hand side variable correct. So I'd be interested in the magnitudes of the supply effects. And then the other is just, this is just a comment to encourage you to look at student outcomes by by race or poverty in the school as opposed to achievement, just because maybe those teacher effects are bigger for those students, even if like the high achieving students among those populations, that would be an interesting cut. But those are my questions. Mark, would you like to ask your question, and then we'll give Bobby a chance to respond?
Sure thing. So Abby, I was actually in the process of typing in a second question to the chat. Is it okay if I sneak in a second one?
Yeah, go ahead.
Okay. So Bobby, this is really interesting. I have two questions. My first one, which is in the chat, is what does reciprocity look like in the EdTPA states? So is it possible that teachers in training could circumvent the requirement by going to a non-EdTPA state that has reciprocity agreements with the EdTPA state? And the second suggestion I had was, these student outcome effects are really interesting. I wonder if you could do another possible placebo test and see if in private schools, we're seeing the similar trends in student outcomes, and whether that trend in student outcomes depends on the fraction of teachers in that school who don't have their license.
Great. Bobby, any reply you want to make?
Oh, thank you, Abby and Mark. So regarding the first question about the magnitude, Abby, you can say it is large or you can say small. So compared to what Morris find and also what Peter and I find before, which is like about 20 to 30%, and also my other paper in real estate licensing, about 20%. So this magnitude 11 to 15% is kind of small relative to the general understanding or previous study. And I think big in the sense that in terms of really about the teacher professions is really big. And I think what we are capturing is the passing rates, because when we look at the official documents in the TPA, the passing rate is about 90%, 80 to 90%. So I think what we are capturing is this one. And so about the heterogeneity of the student race, I remember we did something and we didn't find something surprising. So we didn't put it here, but I think Jen and I can look at it again. And I think this is a good addition too, even if it's no effect. So thanks for the suggestion, Abby. So regarding the reciprocity, Mark, so if you have a license in non-ATPA state, and if you go to ATPA state, you have to be very seasoned. If you get the license in 1 or 2 years, you have to take ATPA. So ATPA is not exempt for new teachers, at least. And for private school, I think this is a good addition too. I think we can run that as a placebo test. Yeah, so I think we can test it. So thank you.
Great. Morris, would you like to ask your question, and then we'll go to Ed, and then you can circle back one more time, Bobby. That'd be great.
Thank you for the paper. Very interesting and informative. So appreciate it. Had a couple questions on how effective the licensing requirements are. So there's as you mentioned, the Teach for America. There's an executive transition program to get executives into teaching. And in states, for example, in a recent year in Texas, 40% of the people who were teaching in Texas didn't have a license. So how do these sometimes very large army of reserve teachers influence your results? And as sort of a market economist, how do wages across states influence shortages? And I would just sort of a very basic market question, how responsive are teachers to wage changes and wage levels across states?
Thank you, Morris. So I think for the teacher from America or other like non-licensure teacher force, for the teacher supply result, I don't think it matters because we are looking at teacher graduate programs. Those programs just designated to train teachers, and those program mandated at TPA. So I think those results are not affected by other pools of teachers. And for the teachers, I mean, for student outcomes, again, I forget whether we mentioned it. We dropped the teachers who don't have licensure. So and so the students' result we find is really the new teachers who went through at TPA. We can actually try to look at whether we see effects for teachers who don't have license, and I think it is also a good placebo test as well. This is something that we don't have right now, but I think it's a good addition. For the wage thing, this is something that we haven't think about it before, and this has been in my head for a long time, like how wages affect selection, especially for teacher, because teacher shortage has been a huge complaint, and wages seems to be one of the dominant factor. So we don't have an answer yet, and we don't have an answer right now. But I think it would be a good future research if we going further, like how ATP intersect with wages.
Great. Ed, do you want to ask your question? And then Bobby, you can reply, and then we'll go to our final presenter, Kihwan.
Sure, thank you. I was just curious, Bobby, I know that a couple of states dropped out of the Common Core, and I wasn't sure if that corresponded with your survey or if that affected your choice of treatment states. So I was just curious about the timing of that and if you accounted for that.
Sure. Thank you, Ed. So in the full specification, we also control for whether there's a change in Common Core's policy. We are not aware of like recent changes because like 2020, 2021 is not in our sample period, but we ensure that in our sample period 2011 to 2019, we take care of those changes.
Great. Thank you, Bobby. And so we are going to turn to Kihwan Bae, who's going to tell us about scope of practice among optometrists, followed by discussion from Ting Zhang. Go ahead, Kihwan. You have 15 minutes.
Can you see my screen and hear my voice?
Yes, great.
Thank you, Abby. Thank you for having us to present our papers on scope of practice on optometrist in this AEA leader session. I'm Kihwan Bae at St. Francis University, and this is joint work with at Timmons in the West Virginia University and the NEE Center for the Study of Occupational Regulation, and Prodding Nandy in Middle Tennessee State University. So in this paper, you will see how the scope of practice expansion for optometrists transform their role in eye care and subsequently improve population eye health outcome. So Alicia Plemmons already nicely introduced what scope of practice regulations in medical practitioners for medical practitioners. So I'll not talk a lot about that. I'll give a couple of backgrounds on eye care workforce and outcome in the United States as a background. First, optometrists became a key eye care provider of the recent decades. So as you may know, there are two types of primary eye care provider in the United States. One is ophthalmologists, who are medical doctors specializing in eye care. Another is optometrists, who are the so-called new eye doctors appeared in the 1970s and 80s. On the left figure here in this page showed the density of ophthalmologists per 1 million people slightly declined from 1990s to 2017. At the same time, the density of optometrists substantially increased from 110 per 1 million people to 160. So it shows optometrists became a very important workforce for a primary eye care provider. Concurrently, visual impairment in the United States fell. The right figure showed the share of people with difficulty in seeing from 1985 to 2012. And it declined despite the well-known population aging, which is a surprise. There may be several contributing factors like advances in medical technology in the 1990s and 80s, or the availability of vision insurance or vision insurance reimbursement policies. However, in this paper, we're focusing on the new emergence of optometrists as new eye doctors, thanks to the scope of practice expansion in the beginning in the 1970s. Optometrists were merely eye examiners by 1970s. All states licensed them in the early 20th century, and they usually measure visual acuity and prescribe eyeglasses or contact lenses. But their role transformed from eye examiners to eye doctors with the scope of practice expansion in the 1970s. From the 1970s, states gradually allowed optometrists prescribe medications for diagnose and treat eye disease or disorders since 1970s. And Medicare, moreover, started reimbursing them as medical doctors from 1986. So one clarification here, in Alicia's paper, she distinguished scope of practice and prescription authority. In our paper, the two concepts are not well distinguishable because, for example, treating glaucoma, one type of eye disease, is not possible to prescribing glaucoma drugs. So these two is sometimes pretty kind of entangled. And in this paper and this presentation, I use the prescription authority expansion as an equivalent term as scope of practice expansion. This paper, our research question is how optometrist prescription authority affected their hourly wages and population eye health outcome. Let me preview our identification and findings. To answer this research question, we use staggered adoption and expansion of optometrist prescription authority across states in 1976 to 2011. For example, all states and DC adopted first the so-called TPA laws by 1998. So our identification used the law changes in all states. And we also account for subsequent amplification laws on glaucoma drugs and controlled substances. It's because some of the first TPA laws in some states only allowed legend drugs, but not other types of drugs. From our analysis, we found the scope of practice expansion had positive earnings and health impact. After the policy change, optometrist hourly wages increased by 12%. And the proportion of people with difficulty in seeing fell by 29%. So this study makes two contributions to literature and current policy debates on scope of practice regulation. This is the first study on optometrist scope of practice and eye health outcome. There are previous studies on laser surgery authority of optometrists, which is just allowed in a handful of states like Oklahoma and Kentucky, and they found limited benefits from that particular type of scope of practice expansion. In contrast, we analyzed the general part of prescription authority expansion for optometrists and found large gains from optometrists, that policy change. Our paper also add a new case study on one of the most transformative scope of practice regulation in the healthcare sector to labor and health literature on scope of practice, or in general licensing. So from now on, I'll talk a bit more details on data, method, and result, and conclude. In our study, we use 3 sets of data. The first one is regulatory data on measures of the scope of practice or the prescription authority of optometrists. We use data compiled by Cooper 2012 on state legislations on optometrist TPA in 1976 to 2011. In our analysis on labor market outcome, we use hourly wages in census and ACS from 1980 to 2010, and we focus on full-time, full-year, non-self-employed optometrists to measure their value of time over time, before and after policy change relative to other states. In the analysis of population eye health outcome, we use a self-reported health status on eye health, more specifically, whether a person have any difficulty in seeing in letters and things, sentences, and the newspapers, which is consistently asked in the survey of income and program participation from 1984 to 2008. And we analyze population aged 15 or above. Let me show 2 figures how states first introduced and expanded their TPA authority across the states. This figure shows West Virginia first introduced TPA laws in 1976, and in 1977, North Carolina followed. So the 2 states are in red color. And the states in yellow color adopted the first TPA authority laws in 1980s. And then the states in blue color allowed the first TPA laws. And first TPA laws typically allowed using legend drugs by optometrists for treatment purposes of eye care, eye disease and disorders. And the DC District of Columbia last allowed this TPA in 1998. And this figure shows how the authority expanded over time across states. 5 lines shows 5 different kind of types of medications allowed for optometrists. So 3 examples. Let me just read a couple of important facts from the figure. So the first bullet point, all states and DC adopted first TPA laws by 1998. And all states except Massachusetts allowed glaucoma drugs by 2004. And Massachusetts did in 2021, very recently. And 43 states allowed controlled substances by optometrists by 2011, which is opioid type painkillers mostly. And to identify the effect of optometrist TPA laws on optometrists' hourly wages and population eye health outcome, we use generalized difference in difference approaches with 2-way fixed effect. So Y is an outcome, S is state fixed effect, T is time fixed effect, P is policy treatment variable, X is individual controls, and epsilon is error term as standards. Here, one thing you need to know is P here, treatment variable wraps 3 policy dummies, not just single policy dummy. We use single policy dummy as well, but our baseline specification use 3 policy dummies on first TPA laws and TPA law for glaucoma drugs and TPA law for controlled substances, respectively. And in our analysis for population eye health outcome, we use that policy dummies assigned without any time lag, and also those with a 10-year time lag based on the medical consensus on the slow progress in eye disorder and diseases. And this CDC 2021 and Susanna et al. 2015 are references for them. And in this econometric model, beta 3 captures the treatment effect of TPA authority. And we will do single and joint hypothesis test on 3 estimates in beta 3. Let me show the results on how the optometrist TPA authority affect their hourly wages first. So column 1 shows differences estimates on first TPA law. So the dummy for the policy treatment variable without any other policy treatment dummies. So the estimate is small and statistically insignificant. Joint test result is presented at the bottom line, by the way. And if we add other policy variables in column 2 and 3, the joint estimates increases, and our baseline specification in column 3, each individual estimates are not statistically significant, even smaller than the first one in column 1, but they jointly became 0.131 and statistically significant at 10% level, which means after the policy change, states allowing prescription authority to optometrists, their hourly wages increased by 0.131 log points, which is similar to 12%. And this table shows the effect of the policy change on population eye health outcome. Here, the outcome variable is the dummy for a difficulty in seeing. Without time lag, the coefficients jointly mostly statistically insignificant and very close to 0. But when we assign the treatment dummies with 10-year time lag, as shown in column 4 to 6, the estimates are around 0.008 to 0.014 and statistically significant at above 5% level. Now our baseline specification in column 6 shows the optometrist prescription authority actually reduced the proportion of people with eye difficulty by 1.4% percentage point, which is equivalent to 29% of the sample average of the outcome. So in conclusion, we found optometrist TPA improved population eye health. The proportion of people with difficulty in seeing declined by 29%. And at the same time, optometrist hourly wages increased by 12%, which may reflect their work's value increased because their work is changed from just eye examination to eye diagnosing and treating activities for primary eye care. And our estimates looks somewhat larger than the one estimated from previous studies, probably due to there's no restriction on optometrist solo practice. Which is sort of similar concept Alicia talked about scope of practice. Optometrists always can practice independently from ophthalmologists or medical doctors. And there may be, but nurse practitioners in some state, they have scope of practice. They have a prescription authority, but limited scope of practice in some cases. And another possible reason to make our estimate larger is
Kihwan, you are a little over time, so maybe if you could just quickly wrap up, then we can give Ting enough time.
Yeah, so there may be possible synergies with changes in insurance and technology with prescription authority for optometrists. And we want to just conclude this scope of practice expansion can be a good way to expand eye care access, and independent practice may be a key to leverage scope of practice expansion. Thank you. This is the end of my talk.
Great, thank you. Ting Ting, go ahead.
I'm waiting for Kihwan to stop sharing.
I did.
Okay, awesome. And just give me 1 sec. Sometimes it's, here we go. Everything looks fine, right?
Great, yep.
Okay. Oh, okay. So thank you for including me in this great panel. And I've been listening to these 4 fantastic papers, and I'm super excited to learn a lot of stuff. And thank you for allowing me to discuss this particular paper. As a parent who's kind of like, dealing with eye care, frequently in the past like a year, this is very informative. So like I resonate with a lot of things like, I learned in this paper. But coming back to discuss like, what I learned in this paper. And first, like this is really a neatly written paper. Like I learned a lot, and then the methodology is solid, and it gives me a lot of perspective in terms of how to understand this. I think it like Kihwan said, this is the very first empirical paper that looking into scope of practice expansion and its impact on kind of optometrics, kind of labor market outcome and patient outcome as well. So I think it adds really great values to the literature. And I want to kind of highlight 2 points that I learned in this particular paper. The first, like big person on visual. So this particular charts kind of make a lot of sense to me. And I also appreciate that like not only the authors bring in the years that the first TPA was implemented, but also like a kind of like subsequent kind of like a policy or regulatory practices changes about the glaucoma kind of treatment, about the controlled substance. So it gives a lot of like depth in terms of what we learned, the progressions of scope of practice that has been implemented across state over time. So that's kind of like one of the major things I learned in this particular paper. And I also kind of like want to bring in the discussion that Alicia made, the point it made in the earlier, right? Like, the therapeutic prescription authority and the scope of practices. And Kihwan mentioned this in his presentation, like it's really hard to disentangle these 2 things in this particular occupation, but like, it's really nice to see, at least we acknowledge there's a wide range of varieties in terms of what kind of like a scope of practices that we are talking about in this particular field, or even in the whole kind of healthcare sectors. And I love these 2 pictures, and I add a little bit kind of like just a line in terms of the year that the first TPA was fully implemented to show kind of like, the trend and how this has been impacted. To me, something really fascinating about these 2 pictures are like, if we separate the TPA implementation by decades, right? Like, that's the 3 different lines that the authors show in their paper, is there's a nice kind of convergence in terms of just a general trend. And it shows a very nice kind of like, this is what we call the homophily, kind of a homophilic kind of effect over time that within the same occupation across different states. And the kind of thing that really motivate me to continue to read the empirical finding is that, like, if we look at the different kind of implementation stage, we didn't really see much in terms of, okay, this first decade, there's a few states that implement this TPA, and there's a huge kind of like a change in terms of hourly wages, in terms of patient outcomes. And the state kind of like, the next decade, those block of like a state that makes changes, and then subsequently things happen, right? But it shows nicely in their empirical kind of like a assessment, saying that, okay, once you have this scope of practice expansion for optometrics, and you have increased, like significantly increase of hourly wages, and you also have the reduced proportion of people with difficulty seeing, right? Like even with a nice kind of like a time lapse. So like I said, overall, this paper is like really neatly structured. The data is appropriate. The empirical method is solid. I mean, like Alicia mentioned previously, there's a huge kind of like a development of, I don't know, accelerated development in the past couple of years in terms of different measures, in terms of like how do we construct empirical paper, right? Like everyone tried to throw the invent study method in that. I don't want to kind of like give a big emphasis on that, because I know authors know what's best, kind of like a method that fits in their settings, fits in their data. But I kind of like, I want to praise the authors, like really put multiple sources of data into the best they can and into address these empirical questions. So everything kind of tied together really well. What I want to talk a little bit more is probably like really the bigger picture question, or like how can we push, like, bring more kind of like a mechanism discussions, bring more like, additional data that really address this what we, because like as economists, right, like we like causal interpretation, right? Like, yes, it's kind of longitudinal data, like we have the nice causal methodology here, but there are a kind of additional discussion I would like to see in this particular study. Here I list like 3 possible things that, you might be able to address or might not be able to address, but like this is something that I like to push and open the broader discussion, right? The first is like in terms of the TPA impact and its relative impact into the total like licensing statures, right? Because like we try to see, okay, this occupation is licensed, that we have been studying for many, many occupations, the impact of licensing status into labor market outcome and, quality of service, all those things. And then now we move to scope of practices, right? So like, how do we reconcile ourselves into this? Okay, we just keep refining the parts, but how conceptually or even contextually understand whether this is actually the thing that matters, right? Especially when we look at the author's kind of result, when we look at the patient outcome parts, right? Like if you see the estimate of the TPA alone, it doesn't really matter as much. But when you kind of start looking into the glaucoma effect, it's kind of like seemingly that this is something that drives the effect. So especially in the healthcare setting, we have the status requirement, we have the scope of practice requirement, and we have the examination versus diagnostic versus treatment kind of things. So it gets layers of a complexity. And this going back to, is this TPA really the cost? I appreciate the author to talk about like, they did some robustness check in their paper talking about like, the changes in contact lens prescription does not really impact the result. Okay, so that's something that reassuring, but still like, if there are other regulatory changes that along the TPA in the same time that could potentially confounding like, the result. And this have also kind of relate to the second point that I want to make, because this healthcare is really kind of crowded field, right? Like, especially for the eye healthcare, we have the eye surgeons, we have the optometrists, we have the opticians, and we have all those other people who can provide some kind of care to the eye in the eye healthcare sectors. So how does the adjacent professions, like their scope of practice, their kind of license status change that impact, this particular line of work that, your scope of practice of optometrists? Because one part that you mentioned in your particular paper is that, because we don't have enough number of eye surgeons, so like, some rationale to really expand the scope of practices of optometrists is because we have shortage of the kind of like, the more strict eye doctors. So that's something that I want to kind of, get some additional explanation. My final point.
Final point.
Final point. Yes, thank you. My final point is really about the healthcare studies, right? Like, we talk about scope practice, we talk about licensing, but in the same time, I get a little bit nervous if we go back to 40 years in terms of study, right? Like, the healthcare system, the reimbursement, all those things like that change the whole sector that needs to be taken into consideration. I know it's a very, very big task, but like I hope like folks who's doing healthcare study can really look into this and find like, some nice ways to address these issues in their research. Yep, so that's it. Thank you for your time.
Thank you, Ting Ting. So Morris and then Wenchen, would you both like to ask your questions?
Sure. You focused on demand, but wanted to know if there are any restrictions of supply over this period that might have influenced especially the wage effects and or outcome effects.
Great. And Wenchen, why don't you go ahead right away? And then Kihwan, if you want to take a minute to respond to whatever, that would be great.
Yeah, I just noticed in the wage table for the results, the sample size is only around 1,000, and I think that makes sense because there are so many optometrists out there. I'm just wondering whether you're worried about the like robustness of this sample size.
Sure, let me answer a couple of things I can now. So yeah, we do worry about the small sample size, and that may contribute the kind of statistical significance of our estimate. It's marginally significant in our baseline signification specification. And question from Morris, the supply effect. So it's related to the comments by Ting Ting. So the licensing of optometrists was done by 1920s in all states. So there's no changes in licensing new kind of license, new states licensed optometrists. And licensing an optician somewhat changed in later years, but maybe not a big changes. And their role, optician's role is mostly dispensing eyeglasses and contact lenses, so that their roles may not significantly affect on the population eye health outcome or optometrist wages. That's our thoughts. And lastly, medical technology and vision insurance things. There's definitely changes in it, but we assume those changes are sort of nationwide changes, and our differences specifications using staggered adoption in optometrist prescription authority may kind of rule out to some extent of the effect of nationwide changes. That's my quick answer. Thank you. Thank you for all comments and questions.
Great. Thank you, everyone. We are at our time. I'm really grateful for all of you and all of the engagement. I think we had a really lively session in spite of having to be here online. So thanks, everyone. Thanks, Morris, again for organizing.
Thank you all.
Thank you, Abby, for chairing. And
Thank
all
you,
your
Morris
work
and
on
Abby.
licensing and getting this